Good afternoon. I'm Angela O'Neill, and I'm here to speak to you today about women's health and neurology. You've been hearing about a number of different disorders, and I can't speak about just one disorder, so I'm going to sort of give you a different lens to look through when you think about your women patients with neurologic disease. I have no disclosures. Briefly, the history of women's neurology. So you probably know that Brigham and Women's Hospital actually happened when there was three hospitals, Harvard hospitals merged. That is the Peter Bent Brigham, the Robert Breck Brigham, and the Women's Lying-In Hospital to form the Brigham and Women's Hospital. So really at the conception of the hospital, women's issues were key. And it was the brainchild of my former chair, Dr. Samuels, who decided to join two of our major areas of expertise, neurology and women's issues, to form the first women's neurology program ever. So what is women's neurology? And I'm going to try to share with you through some cases how to think about this. So we have neurologic disorders which affect women at different ages. For an example, multiple sclerosis. And what the issues are going to be for your women patients depend on where that woman is in her life cycle. So if she's a young multiple sclerosis patient, you're going to be thinking about reproductive issues. An older woman with MS, you might be thinking about things like bone health. Then there's some disorders that only affect women during pregnancy. Eclampsia would be an example, and certain kinds of strokes are much more common in pregnancy. So my objectives today are to discuss sex-specific disease concerns, the pathophysiology as it relates to sex, and treatment-specific concerns for women. And I'm going to use as an examples multiple sclerosis, migraine, stroke in pregnancy, eclampsia, and then stroke risk factors. So in a young woman, what are the issues that you really should be discussing? First, I think family planning. So the most important question I want to ask a young woman is, are you planning on getting pregnant in the next year? Because that's going to inform how I approach treatment, and certainly it will be helpful to discuss those kinds of issues with her early on. We want to discuss medication risks in pregnancy. We also want to discuss the effects of pregnancy on the underlying disease, and the converse, the effects of the underlying disease on pregnancy. This is the FDA pharmaceutical pregnancy categories, and I know we've moved away from that and we talk about risk versus benefit. I think in some ways this helps formulate my thinking a bit, and I'll just share with you some thoughts about this. So category A, adequate, well-controlled human studies, no risk to baby or mom in the first trimester. It's a bit of a fairy tale, with the exception of magnesium, where most of the time pregnancy is an exclusionary criteria for most clinical trials. The second thought I want to just share with you is that we're trained that a B is better than C. But the category risk really depends on the information that is known about the medication. So for example, clopidogrel is a category B, and aspirin a category C. Yet the maternal fetal medicine physicians have a huge experience using low-dose aspirin in pregnancy. Other thing that you have to think about is that the medications change according to what trimester patient is in. So for example, non-steroidal anti-inflammatory medications are category B in the second trimester, but become a category D in the third trimester because of risk of closure of the patent ductus arteriosus. And last is that whatever the risk is also related to what the disorder is. So valproate, when it's used for epilepsy, is a category D. But when it's used for a more benign condition like migraine, it becomes a category X. So let's move in and talk about reproductive health and pregnancy concerns. And I'm going to start with some examples from multiple sclerosis. So here we have case one, a 28-year-old woman. She has relapsing remitting multiple sclerosis. She has stable disease. She's on interferon beta 1b and an oral contraception. And she wants to get pregnant. So which of these statements are true? A, pregnancy increases the risk of an MS relapse. B, neuroaxial anesthesia should be avoided in MS patients. C, postpartum MS patients need to resume their disease-modifying therapies, so breastfeeding is not appropriate. Or D, pregnancy does not increase MS disability. All right. The answer is D, pregnancy does not increase MS disability. So the pregnancy relapse in MS trial, which I'm going to share with you in just a moment, clearly showed that the relapse rate 1 year postpartum is the same as the relapse rate the year prior to pregnancy. So multiple sclerosis disability did not change related to pregnancy. Here are the immunomodulating agents that we use during for treatment of multiple sclerosis. I listed their FDA class, their half-life, maternal-fetal risks, and secretion in breast milk. Just a few points on this. Glutaminyl acetate is actually quite safe. It's a category B. There are some neurologists who will actually continue this during pregnancy. My MS colleagues do not, and I'll share with you why. Teriflunomide is a category X. Now, it also has a very long half-life, and you have to undergo this accelerated charcoal elimination. So this is not a medication that really should be used for women in their reproductive age unless all others have been excluded. And also interestingly, that if a man wants to father a child and he's on this medication, that he has to actually undergo the accelerated charcoal elimination. Last point was naltizamide has a 15-day half-life, so usually they want to stop that with several months prior to trying to conceive. And there is a rebound effect after you stop that. So oftentimes EMS people will have women on monthly prednisone dosing to try to prevent that rebound prior to conception. So what is the effect of estrogen on the immune system, and what is the effect of pregnancy? So multiple sclerosis is an autoimmune disease that is driven by T cells. And in the non-pregnant state, there's an increase in T helper cells, and that drives inflammatory compounds which destroy myelin and the underlying axons. Now, pregnancy is a relatively high estrogen state, and it is a state of relative immunosuppression. And the fetus needs to protect itself from being rejected, basically. And that what happens is there's actually an increase in T suppressor cells and an anti-inflammatory response. Here's the pregnancy relapse in MS trial that I said I was going to share with you. This is a trial that was published in 2001, I believe. And it's a prospective trial looking at patients with relapsing remitting multiple sclerosis. 254 women were followed through their pregnancy. So if you look at the relapse rate, the annual relapse rate the year before pregnancy, it was 0.7. During pregnancy, you can actually see that in the third trimester, the relapse rate goes down. There is a small bump in the postpartum period of the relapse rate going up to 1.2, but 1 year postpartum, the relapse rate is essentially the same. So again, this demonstrates the fact that pregnancy had no overall effect on the annual relapse rate, and disability was stable. What about breastfeeding? Well, first, who's at risk? Well, from the PRIMS trial, we can see that the women who had high relapse rate in the year before pregnancy, and with the postpartum increase in relapse, those are the women that would be most of risk to have a relapse. And those are the women we would encourage to get back on their disease-modifying therapy early. There are some small trials looking at breastfeeding, and I'll share one of those. 32 pregnant women were with relapsing remitting MS were matched with 29 controls. And of the 52% of the patients with MS who did not breastfeed, they actually had a relapse rate of 87%. So this is exclusive breastfeeding. Now, again, there's a small trial. It wasn't controlled for disease severity. There's been several other small trials, which I've listed there, all supporting the idea that exclusive breastfeeding actually is helpful in decreasing MS relapse. And we're not sure why. It may be that the lactational amenorrhea is associated with decreased risk. So let's talk about another neurologic condition, which is quite common, migraine. And think about this through the lens of women's health. So here I have another 23-year-old woman. She has migraine without aura. She's now 8 weeks pregnant. Her migraines had been well controlled with sumatriptan. She's now having her usual headache with nausea and vomiting several times a week. So the second question, migraines during pregnancy. They A, often improve by the second trimester. B, are not associated with any pregnancy complications. C, should be treated in a similar fashion as migraine outside of pregnancy. D, can be treated with botulinum A. All right. The answer is A. You guys are good. They are often improved by the second trimester. So the epidemiology of migraine during pregnancy is that migraines, particularly migraine without aura, which is the more hormonally driven migraine, decreased by about 70% by the early in the second trimester. This is a classic picture looking at prevalence of migraine prevalence on the y-axis and age on the x-axis. The stippled line are women, and the solid line men. And if you look at that, the curves start to diverge at around menarche and come back towards each other at menopause, showing that women really have 3 times more migraine than men. And so there's clearly a hormonal component to migraine. So to bring home the point that 60 to 70% of migraines undergo remission. And again, this is often more common in migraine without aura. Migraine with aura can actually come on first with high estrogen states. So usually it's migraine without aura. There is a small, as I said, small percentage of new onset migraine during pregnancy, and these are usually migraine with aura. And migraineurs do have an increased risk of preeclampsia and eclampsia. So the most important thing about migraine is to plan with your patient. In general, we would want to do is non-medical things such as lifestyle modification, stress management, that kind of thing, that if we can. We generally go to symptomatic therapy and do not use preventative therapy except with rare exceptions. Other modalities such as physical therapy, if there's a myofascial component to the headache, or occipital blocks can be used as well. And some of the neuromodulatory devices are also likely to be quite safe. Here's a list of some of the symptomatic medications that we use during pregnancy, their level of risk, and their breastfeeding information. So just a couple of points. The nonsteroidals we already talked about, that they're category D in the third trimester. They can be used in the second trimester, but I have to say I often avoid them because of women sometimes forgetting where they are in their pregnancy. Metoclopramide is a very effective migraine symptomatic therapy and is safe both in pregnancy and breastfeeding. We avoid the ergots. Magnesium, as far as symptomatic therapy, it's only helpful symptomatically if it's given IV. The reason magnesium has a D behind it is because with 5 to 7 days of high dose magnesium, like for tocolytic therapy to prevent labor, there have been reports of rickets in the babies. Triptans we'll talk about, but they are category C, but we actually have a fair amount of data supporting their safety. And then the new kids on the block, the ditans, the gepants, we just don't have any information, so best to be avoided. Here are the preventative medicines, and you can see that none of them are totally safe. We talked about valproate as a category X, not only because of neurotube defects, but also neurocognitive problems with offspring exposed to valproate. The CGRP inhibitors, again, no data on these. So in general, we have a benign condition, which is most commonly is going to get better. So try to avoid symptomatic therapy as much as possible. So I told you I was going to talk a little bit about triptans in pregnancy. So we do have some data from the sumatriptan nartriptan pregnancy registry, excuse me. There was about, it was a 16-year registry, 680 some patients were followed, exposed to triptans, and no major congenital malformations noted. There's a lot of data from the from Norwegian mother-child cohort where 70,000 women were followed and over 1,500 triptan exposures. And again, no major congenital malformations noted. There was a slight increase in bleeding risk with triptans used close to delivery with about 500 cc's of increased blood loss. But I think in general, we would think that these look to be quite safe. We don't have, again, and they're not my first line, but if a woman has intractable migraines and I know they have responded to triptans, I think it's a reasonable second line. Migraines and postpartum, so the triptans are quite safe. Multiple preventative medicines can now be used as well, including many of the tricyclics and beta blockers. This LactMed is a great resource place. You just put any medicine you want to use in the postpartum period and it will tell you about breastfeeding risk. So now we're going to go from talking about some of the reproductive issues and neurologic problems and talking about some pregnancy-related disorders. We're going to start with ischemic stroke. So here's a 28-year-old woman. She's G2, P1 at 30 weeks of gestation, last seen well at 10 a.m., and she's found in the ground. She's not speaking and not moving her right side. She's found at 10:50. So that occurred at 10:50. Her initial exam at noon, she's mute with a left gaze deviation and a dense right hemiplegia with an anti-stroke scale of 15. So here's your question. Which of the following statements is true of ischemic stroke in pregnancy and the postpartum? A, brain MRI, brain and neck MRA are the best imaging modalities. B, IV TPA should not be used in pregnancy due to fetal risk. C, head CT and CTA of neck and brain are the most appropriate imaging modalities. D, the causes of ischemic stroke during pregnancy and postpartum are similar to those that occur outside of pregnancy. So the answer is C, head CT and CTA of neck and brain are the most appropriate imaging modalities. So stroke is a neurologic emergency, okay? And in the setting of a neurologic emergency, we need to do what is most appropriate to with this condition. And so we need rapid imaging, rapid vessel, both brain and vessel imaging. And so the evaluation and treatment of stroke during pregnancy should be in the most cases driven by the severity of the stroke, and is really the same as in the non-pregnant state. If the patient had a very mild deficit, you could consider an MRI and MRA, but the time is such a valuable commodity here, we would immediately do a head CT, a CTA, given the severity of this woman's stroke. The concern about using CTs, there's two concerns. One is the deterministic effects. That's where after a particular dose of radiation, there's a threshold on which you're going to have an effect. And here's an example of a burn related to radiation. Any of our modalities that we use for imaging, including four-vessel arteriogram, are well below any kind of deterministic effect. The real concern is for what we call stochastic effects, and these are an effect that there is no threshold. You either have it or you don't. An example would be cancer, right? The cancer risk is related to who you are, if you're a child versus an older person, and the dose. So this is the concern. So we're going to go back to the patient. The patient actually had a head CT scan and then received TPA. Then this was at an outside hospital. They had the MRI, which you can see on the right, the diffusion weighted image, and on the left, the ADC. So there's a deep infarct involving the lenticular striate arteries, and there's a cutoff of the middle cerebral here with the arrow. So again, what is the experience or what is the data to show that TPA is safe? Well, we only really have case reports because, again, pregnancy was an exclusionary criteria for the NMDS, the trial that got to that put TPA on the map. But what we know is that for the most part, fetal, maternal outcome and fetal outcome parallel one another. So if you have a sick mom and you don't treat her, baby's not going to do well. So in general, we would, again, as I said, treat mom according to her stroke. If she has a mild stroke and doesn't require TPA, that's fine. But if she requires TPA, we would give it to her. As far as thrombectomy, there's even less data, but it's a similar kind of thing. Again, only a limited case reports, with maternal outcome when given good, and baby's outcome mimics that of mom. Causes of ischemic stroke in pregnancy are quite diverse. What the most likely cause really depends on where you are seeing the patient. So at a tertiary care hospital, cardiogenic emboli and stroke related to preeclampsia and eclampsia are the most common etiologies. But there's other things that we need to think about: cerebral venous thrombosis, reversible cerebral vasoconstrictive disorders, amniotic fluid emboli, choriocarcinoma. But so it's quite a diverse cause of stroke. Okay. So now we're going to go and briefly talk about eclampsia. Here's a 35-year-old lady. She's G1, P0 at 31 and 5/7 weeks of gestation. She wakes with the severe headaches. She's seeing visual spots. Half an hour later, she loses her vision. Then she develops one of the worst headaches she's ever had and blacks out. Her blood pressure is 170/120, and she was transferred to our hospital. Here's the next question. Preeclampsia is no longer associated with significant maternal morbidity or mortality. B, caused by abnormal placental implantation. C, not associated with long-term maternal sequelae. D, has no radiographic correlate. E, is defined by hypertension and proteinuria. The answer is B, it's caused by abnormal placental implantation. So basically the cascade of events that initiate preeclampsia and eclampsia actually occur at the time of the placental implantation. This leads to ischemia, driving hypertension, and causing endothelial injury. The proteinuria part of the definition is no longer required as part of the definition. So the hypertension, but the proteinuria portion has been deleted from defining preeclampsia. Okay, so what are the red flags when someone has headaches? And I think the red flags are these. One, a change in the headache character or pattern. So for instance, I saw a patient today who is pregnant, has long-standing migraines with and without aura, but reports a headache that happened about a month ago, which was thunderclap in nature, associated with severe neck pain and vertigo, none of which she'd experienced with her prior migraines. So that's a red flag. Headaches with characteristics of elevated ICP, those are wake-up headaches worse with cough or sneeze. New headaches, right? New headaches who've never had a headache before. Most of you've heard about the definition of migraine or other primary headaches, but new headaches, you have to be concerned. Headaches associated with elevated blood pressure, an unusually severe headache or thunderclap headache, abnormal neurologic exam, and those headaches are associated with other systemic disorders like a coagulopathy or underlying cancer. Those would all be red flags for imaging. Here's looking at the headache type by trimester. So if you look at it, migraine is by far the most common headache that neurologists see during pregnancy. It's a very common primary headache. But if you look at here's the danger zone, the postpartum, 2/3 of new headaches in the postpartum period are secondary headaches. So it's when the headache occurs during pregnancy and postpartum is a helpful clue. For example, idiopathic intracranial hypertension, used to be called pseudotumor, is commonly, if it's going to occur in pregnancy, occurs with the rapid weight gain. And that usually happens between the first and the second trimester. Headaches associated with preeclampsia and eclampsia are not going to happen until after 20 weeks. Cerebral venous thrombosis pregnancy is a hypercoagulable state. It's particularly going to be a more problem as you get towards delivery and in the postpartum period. And then post-dural puncture headaches, of course, if they're going to happen, they're most commonly after neural axial anesthesia, so that would be in the postpartum period. So preeclampsia is diagnosed when a pregnant woman has high blood pressure with at least two separate blood pressure readings 6 hours apart of a greater than 140 systolic and more than 90 a diastolic. The 300 milligrams of proteinuria in the 24-hour urine sample is no longer required as part of the definition. When a woman has seizures and change mental status, then we call that eclampsia. So here's the pathogenesis of eclampsia. I pretty much guarantee you're not going to see a picture of a uterus in many neurologic talks. But on the far right is what's supposed to happen. So the cytotrophoblasts invaginate into the uterus and go all the way into the uterine myometrium, and they set up a low capacitance maternal fetal placental unit. That does not happen when eclampsia is going to occur, or preeclampsia later down the line. And so that sets up an ischemic non-low capacitance unit, which drives the pathophysiology. So why are we concerned about preeclampsia and eclampsia? Well, preeclampsia is associated with significant maternal and fetal morbidity and mortality. For mom, the complications include abruption of placenta, DIC, acute renal failure, stroke, hemorrhage, death, and long-term cerebrovascular and cardiovascular morbidity and mortality. For the baby, the complications include premature delivery, low birth weight, hypoxic injury, and death. Sorry, this cut off a bit, but the pathogenesis, so there's genetic factors that predispose towards some women having preeclampsia. There's also immunologic issues that predispose, but the core feature is that there's this the low capacitance placental unit is not formed, and that sets up an ischemic milieu and causing endothelial injury, which is driven by hypertension. And then what happens depends on which end organ you look at. So if you're having endothelial injury and you look at the kidney, you're going to get proteinuria. If you have endothelial injury in the liver, you get activation of the coagulation system, and you get the hemolytic anemia, elevated liver enzymes, and low platelets, the HELP syndrome. And in the brain, with this endothelial injury, you often get seizures, changes in vision, confusion, vasogenic edema, and you get stroke and hemorrhage. And it turns out that the posterior circulation, we think, seems to have less ability to autoregulate. And so these changes are more commonly seen in the occipital and parietal lobes, explaining why the neurologic symptoms, the visual changes, the confusion that these women commonly have. There is a radiographic correlate, so you can see what's called the posterior reversible encephalopathy syndrome associated with preeclampsia, and this causes headache, seizures, changes in consciousness, and visual disturbance. And here's an example of axial flare image with white matter changes consistent with the Proust syndrome, with white matter changes in the posterior occipital lobes. The treatment for eclampsia and preeclampsia is rapid blood pressure control. Labetalol is commonly used, but calcium channel blockers could be used as well. And magnesium sulfate is used both for the prevention of progression from preeclampsia to eclampsia. That was the landmark trial there was called the MAGPIE trial. And then it's also used for eclamptic seizures. There was a big debate for years between the neurologists and the obstetricians. The neurologists thought that the obstetricians were out to lunch, that they wouldn't be using phenytoin, but instead were using magnesium. And then a big trial came out in 1995, which showed clearly that magnesium was much more efficacious than phenytoin. All right. So now we're going to talk about an example of postmenopausal women's issues, and I'm going to use stroke as an example. So this is our fifth case. Is a 76-year-old woman. She has a past medical history of diabetes, has new onset of atrial fibrillation. She doesn't smoke, drinks 1 to 2 alcoholic beverages a week, has never had a TIA or stroke. She's normotensive and not overweight. So what kinds of sex-specific questions should be asked, and what is her stroke risk? So here's the question. All of the following except are stroke risk factors in women. Atrial fibrillation, gestational diabetes, gestational hypertension, migraine without aura, and preeclampsia. All right. You guys nailed it. Migraine without aura is not a stroke risk factor. So migraine with aura is a stroke risk factor in women, but not migraine without aura. And atrial fibrillation, gestational diabetes, and gestational hypertension are all unique risk factors for women. So the migraine with aura doubles your risk of stroke. The risk is still extremely small. It doubles it from 1% to 2%. But on a population basis, this is an important issue. But migraine without aura is not a risk factor for stroke. So stroke is still the third leading cause of death in women. And usually when we think of risk for stroke, we think of across most age strata, women have a lower ischemic stroke risk than men. But in the older age groups, and particularly in women greater than 85, women actually have a higher or similar incidence of ischemic stroke as men. And because they're older and have a longer life expectancy, their disability is actually higher. So it's actually has a huge total burden of risk. So what about pregnancy complications and long-term stroke risk? So if you look, if this green line is sort of the threshold above which you're going to have symptoms, is basically pregnancy is a stress test, and it's going to, and those women who have complications related to the pregnancy, such as gestational diabetes, pregnancy-induced hypertension, and preeclampsia, means that those are women who are at higher risk than women who had none of those pregnancy complications. So, for example, gestational diabetes, if you have gestational diabetes, your risk of having diabetes is 50% within the next 5 years. Hypertension, a risk of having, if you have pregnancy-induced hypertension, you have a 4 times higher risk of adding hypertension later. And preeclampsia at least doubles your risk of stroke 10 years or more down the line. Here's some data looking at some retrospective cohorts, which looking at preeclampsia and stroke in later life. And the odds ratio of course, it looks at which studies are variable, but it's about double, or in this last trial with very severe preeclampsia, up to 5 times odds ratio of stroke risk. So this is a huge place where, as primary care providers, you have the ability to intervene. Atrial fibrillation is an independent risk factor for stroke. So those of you who use the CHADS VASC risk calculator, you get an extra point if you're a woman. And that came from several large cohort trials There's a large trial of over 100,000 patients with non-valvular atrial fibrillation in Sweden. And the incident risk of ischemic stroke was greater in women than men. So for women, it was 6.2% versus 4.2% incident risk per year. It's not clear why that is, but clearly it's an independent risk factor for stroke. So for a woman over 75 who has new onset AFib, they're much more likely to require anticoagulation. Because of the differences in stroke risk for women versus men, the American Heart Association and American Stroke Association came out with this paper in 2014. It's extremely detailed and well written. I would really encourage you to look at it. But basically saying that women who have preeclampsia have about twice the risk of stroke, and those with gestational hypertension at least 4 times the risk of developing hypertension later on, which, as we all know, is one of the highest risk factors for stroke. So again, double the risk factor for stroke and hypertension. Again, atrial fibrillation is an independent risk factor, diabetes, migraine with aura, and turns out depression and emotional stress may be higher risk factors for stroke in women as well. How that is because of secondary lifestyle issues or not is not entirely clear. So I've taken you on a bit of a whirlwind tour of thinking about some of the women's issues in neurology. Talked about a number of different disorders and how you can need to sort of take a different lens to look at those. And so for reproductive and pregnancy concerns, we used MS and migraine as an example. Pregnancy, we talked about stroke and eclampsia and preeclampsia, and then he used ischemic stroke as how women are different than men as far as their risk factors. I'm going to end with this. I hope this has been somewhat helpful, but here's an attending at a tertiary care hospital explaining in detail what's wrong with a patient. So hopefully I've given you a bit more insight than this faculty member. Anyway, thank you very much for your attention, and hopefully I have time for some questions.
Dr. Neal, thank you so much. That was really great. And you are correct. I didn't expect to see a piece of a uterus for a neurology talk, but thank you. That was really great. We do have a couple of questions. One of the questions has to do with migraines and triptans. And is it a category X?
You're cutting out, Galen. Okay, so migraines and triptans, are we talking about pregnancy?
Yes, in pregnancy.
So triptans are actually, they've been categorized as a category C. I tried to show you some data to explain that they're actually, looks like they're quite safe from everything that we know. It's pretty common for women, particularly in the first trimester, not to know that they're pregnant and to have used triptan. So there's never been any major congenital malformations associated with the triptan. I use them not as first line treatment for migraine in pregnancy, but as the second line, and particularly those women who have refractory migraine who are ending up in the ER on a regular basis. So the data is we have most robust data for the sumatriptan because that's the oldest triptan. But I think that they probably are quite safe.
Okay, great. The next question for the pregnant patient, if proteinuria is no longer required, how do you differ between hypertension and preeclampsia?
Oh, really good question. I hear my maternal fetal medicine colleagues going back and forth on this all the time. It's sometimes very, very difficult. So they use it as sort of a secondary criteria, but I think it can be very difficult to distinguish the two. So part of it is timing when it comes on and the acuity and what other things are going on too. So, but it can be hard.
Next question, are elderly women with stroke and atrial fibrillation at high risk of bleeding if they are on anticoagulation.
Well, yeah, so being older puts you at risk for fall, but you have to fall a whole lot to overcome the risk of atrial fibrillation. So it turns out that the elderly actually are the people who benefit the most from anticoagulation, and you have to have a very high fall risk. But I can put this back to you, Galen. What do you think about that? Because you're a stroke expert.
The answer is yes. I think for those women of low body mass index above age 75, there is a higher risk for having a spontaneous hemorrhage on anticoagulation. But it doesn't negate the benefits overall of anticoagulation, but that risk is higher. So it is worth a very long discussion for that patient.
Yeah.
Okay. Next question is, I guess it's the questions regarding clarification of what preeclampsia is in the pregnant patient. So 2 measurements of the systolic blood pressure greater than 140 during pregnancy, is that preeclampsia?
If it occurs after 20 weeks, again, yes.
Okay, great. That's all we have right now for questions for this section. So thank you so much. That was really fantastic.